Hello everybody. Today we'll be speaking to you on echo for ECMO. Why do we need a modem such as echocardiography for a successful outcome on ECMO? The answer is very simple. We use it to choose our patients judiciously. We use it to put all our cannulas of the right size in the right place. We use it to monitor our patients well so that we have successful outcomes, and we also use it to see complications like thrombosis and venous scarring around these cannulas. And finally, echocardiography helps us in weaning the patients from ECMO. ECMO, the veno-arterial or the veno-venous as we rightly know about it, first started by Robert Bartlett in the world on a meconium aspiration patient who was coming for an ASD, is an excellent tool to save a failing heart as well as failing lungs. So whether we use ECMO for an ARDS patient with a veno-venous ECMO, or for a patient with myocarditis, cardiomyopathy, or in a low cardiac output following cardiopulmonary bypass, we always would need echo. And echo has become like the run of an ACT because we give heparin, very essential to choose our patients. So let's say to select the patient well, do we need an ECMO on an AR patient, or a patient with aortic dissection, or a patient with an intact interatrial septum? No, a PFO or an ASD. The answer is a big no. So when you choose your patient, you must be able to see a clear SVC, a clear IVC, a mid cavity of the right atrium. You do not see a right atrial appendage on a TEE on an echo, but you see it very beautifully on a transthoracic echo. And simultaneously, when we are ruling out our patients, echo also helps us to choose the right cannula, because percutaneous cannulae, the right sizing of the cannulae. So if we are using the femoro-femoral bypass on ECMO for a veno-venous ECMO, then to choose the right femoral vein and the femoral artery, an echo or an ultrasound imaging is essential. Similarly, an SVC or an IVC to do a veno-arterial ECMO and the position of the RA is again essential. So choose the correct cannula, see the cannula placement, rule out any LV distension or RV distension on an RV dysfunction, see the worsening of the mitral regurgitation or the tricuspid regurgitation, decide on an LV venting with a balloon atrial septostomy on an LV vent through an ECMO circuit. You need echo, and 2D as well as 3D echo now beautifully portrays to you the presence of a thrombus. What are the three dreaded complications of ECMO? They are bleeding, they are infection, and they are thrombosis. The moment you throw out a clot into the brain or into any appendage or into the lungs, the drainage of the ECMO flows decreases, recirculation sets in, ECMO becomes disastrous. So for all this, echo is very essential. And what better than using an echo in a dying heart so that you can judiciously maintain the ECMO process. Do it twice a day, do it thrice a day, see a migrating cannulae, see a cast around the cannulae, and decide to pull out your cannulae, reposition them so that the ECMO flows continues. And when you decide to wean the patient off ECMO, when all other parameters are right, again to wean it off ECMO, what is the condition of the heart, the four chambers? Is there any stasis of blood in the ventricles or in the aorta or in the left atrium? Echo tells you everything, even about a small thrombus. Most chiefly, it tells you the return through the great vessels, the four chamber view on mid-esophagus, the upper aortic arch view to tell us about an IABP, which may be concomitantly put with an ECMO, modified bicaval view to tell you about the intact atrial septum, the migration into the LA of the cannulas, the SVC or the IVC are all parameters, and of course the LV function, the LV ejection fraction, the LV end diastolic volume are parameters which an echo can tell you beautifully on ECMO. So keep doing echo on ECMO and see your ECMO patients survive better. Thank you for your patient listening. To learn more, please join us at our website on the Simulation Society. It's open for everyone to come and learn from us how to judiciously use echo on ECMO.